Good morning and welcome to PACT Digital Health Series. I'm Dean Miller, the President and CEO of PACT, and I first want to thank our sponsors this morning, Dwayne Morris, Eisner Amper, and Independence Blue Cross. We've got a great program here this morning for you. As you see, we're in Remo. We use different platforms for different purposes, and we're excited to utilize this platform. You're all muted. You can use, just like in Zoom, the Q&A bar to ask panelists questions. We'll moderate those and make sure that we answer them. And the chat window is available for all attendees to comment, say hello. And of course, this platform provides the opportunity, which you'll have the chance to do, to go back to your tables and have conversations. With that, I would love to introduce longtime PACT member and incredible supporter, Kurt Schiller. Kurt is the head of content marketing and one of the executives at Arcweb. Arcweb, as you know, is one of the leading technology providers in our region, serving many companies both in our region and beyond, and have a real special focus in the healthcare space. So with that, let me turn it over to Kurt.
There we go. Well,
All right, Kurt.
I got it, I think. Yeah, thank you. Thank you very much. Excellent intro. I really appreciate that. And good morning, everyone. And for coming out this morning. So like Dean said, my name is Kurt Schiller, and I am the head of content marketing and a healthcare analyst at Arcweb Technologies. And we're a digital transformation and product agency that specializes in product strategy, design, and custom software development with a particular focus on the healthcare industry. Just a little background about me. I've been with Arcweb for about 4 years, before which I worked on digital strategy in the Medicaid managed care industry. And I also spent a number of years as a technology journalist. And I'm excited to be joined today by Cliff Cavanaugh, who is the Chief Technology Officer at Healthjump.
All right. Can you hear me okay?
Yes.
Excellent. Excellent. So, hey, thanks for the intro, Kurt. And I'm very, very happy to be here. So as Kurt said, I'm Cliff Cavanaugh. I'm the CTO and founder of Healthjump. Healthjump's mission and vision is to make all medical record data available to every member of the care continuum, not just doctors, but also patients, family members, and also analysts and researchers. I've been in Philadelphia my whole life, and been a healthcare technology nerd for about 15 years. And I'm real excited to talk to you, Kurt, and real excited to be part of the PACT team here today.
Likewise. Yeah. So I guess that's a good place to start. So we're talking today about opportunities in healthcare data. So let's kind of set the stage about that. Healthcare obviously is this huge, complex market with a huge footprint, both in the Philadelphia region and really, I mean, in every part of everyone's lives in one way or another. It's an industry with a lot of moving parts, a huge number of very well-established players, and historically, it's been kind of a little bit isolated from a lot of other industries. I often hear people just kind of say, you know, we are a healthcare company, as if it's like a binary thing. Like you're either a healthcare company of some sort or you're not a healthcare company. It's a very in or out of the industry question. And healthcare data, whether that be clinical data, demographic data, billing data, or one of the other dozens of subsets of other types of healthcare data, is really almost a niche unto itself, with its own intricacies and specialized ecosystems. And so I think a great jumping off point would be to kind of ask the obvious question, or to kind of talk about the obvious subject of, you know, why should anyone care about this incredibly specific, incredibly complicated, subset of healthcare data from a business perspective, especially if they're not in a traditional healthcare company?
Yeah, that's a good question. I mean, from my perspective, it's almost like as a patient, right? I think about healthcare through the lens of the care delivery system, right? Well, what is healthcare? It's like I go to a doctor, or I need to go to the hospital for some reason. Maybe I need to go to a pharmacy and pick up meds and so on and so forth. But healthcare is becoming more and more like other industries, where a big component of healthcare is technology. And especially when it comes to data, data is so important in every industry, and that's no different in healthcare. I think it's exceptional in healthcare, and it's the same technology that that powers the ability to harness value out of data. It's the same technology in other industries that can be used in healthcare, and so and any company, whether it be a startup or anything that is providing a whether it be software service or in a lot of cases even physical services, um, they they need to be thinking about if that could be used to benefit healthcare. And given that healthcare data is available, but we see the dynamic changing of how even we as patients receive care. I'm sure a lot of folks on the call have experienced at least one or more telehealth visits this year, and they never did before. And so take a company like Microsoft, and they have a product, Teams, that is now integrating with EHRs to facilitate telehealth visits, right? And so one wouldn't think that communication like this would need to happen via a healthcare company. It doesn't. It really pertains to every and any company or any and every platform. And I should say every and any platform should be thinking whether or not they could be useful in healthcare. Not that they will be, but I think it's something that we should all at least be thinking about.
I agree completely, and you made this point about kind of how there's this valuable data that's just kind of like being created and floating around. And I have a statistic actually about that, which is from 2018 to 2019, healthcare organizations saw a 900% increase in the amount of data that they had. And I think that the total amount of healthcare data in the world last year was something like 2,300 exabytes, which is 1 billion gigabytes. And the rate at which that increases is frankly just absurd. And the vast majority of that data it's just kind of like it's used when it's convenient or when there's an opportunity identified. But there's so much of that opportunity, I think, has been almost like this massive reservoir of potential value that's out there, that until fairly recently has been extremely difficult to do anything with, even with full permission from the people who created and in theory own that data. Although I think I'm sure something that we'll touch upon is this question of kind of like who really owns and how accessible is it really. But your point about this could be a healthcare interaction,
right?
And I think in the past we've had this very binary view of something either is for healthcare or it isn't. So when from my background working in managed care, we would often encounter like a healthcare version of a product that existed in the consumer or the general business market. And because the kind of like Zoom is like a perfect example. 5 years ago, the idea of using Zoom for a healthcare interaction would have been out of the question.
Right.
It would have been something like, well, we need a healthcare specific Zoom because it's this very specific niche. And if you're not a healthcare company, like you can't play in this pool. And we're increasingly seeing, like you alluded to, existing products and existing players are realizing that, well, no, our technology isn't really any different from healthcare technology. A lot of the same technology is the same. Something that we always say at Arcweb is the biggest challenge is not the software architecture, it's the human architecture of doing healthcare. It's all of the regulations, it's all of the people, it's getting the buy-in, it's managing permissions, it's understanding the way that people engage with these deeply personal, deeply complex things. And increasingly, it's one of those things where like the tide has come in and washed into the tide pool, and all of a sudden there's new fish.
Yeah.
And it's this thing that touches every aspect of our lives. And as an innovator or an entrepreneur, I don't know why you wouldn't want a hand in shaping that. It's such a huge aspect of our lives. So I think, as innovators, as entrepreneurs, and just as patients too, honestly, it behooves us all to really pay attention to it.
Yeah. And that said, I don't want to say that the timing it couldn't be better, because that's gonna sound a little glib considering the situation that we're in. But I did hear, I'm going to butcher the quote, but that if there is an area that needs change but is resistant to change, then one way to affect change is after a shock to that system. And I might have butchered the quote, but hopefully I got the point across. And that is that all of the things that would prevent healthcare from moving forward, and healthcare data, and what you just mentioned, at the how it's growing exponentially to be utilized and valued. If there was any time for anybody that does have an entrepreneur hat on, an investor hat on, et cetera, to look at this industry that is ripe to now adopt some change, I feel very strongly that that now's the time. And so I'd like to chat a little bit about that, if we can transition just a bit to this past year, right? And maybe you could tell me, Kurt, what has your observation been on how people are approaching not just healthcare in general, but even specifically healthcare data?
Yeah, I think there's a real eagerness, to the topic of this chat. There's a real eagerness, I think, from outside of the healthcare industry to see if there's ways to apply existing products, existing technologies to healthcare. There's we talk with a lot of entrepreneurs who have come up with a potential killer app, something that they've identified, and I'm sure all of us have shortcomings in the way that we deliver healthcare. I saw Frederick Jones in the chat just asked this great question about couldn't we adopt a national system like the Netherlands rather than this fragmented competitive private solution? Yeah, there's so many ways that you could change and transform the healthcare industry, and I think the last year has made people realize and really take stock of the fact that things can change very quickly. Like you mentioned before, a lot of people have probably had telehealth visits over the last year. Among them, people who 2 years ago would have said, I'll just go to the doctor's office. And all of a sudden, there's this little sea change, or little sea change, this huge sea change suddenly made something that was of no interest to people mandatory. Now, any, medical practice that has wanted to actually stay in business and turn a profit over the last year has had to come to grips with the challenge of delivering healthcare remotely. And I think people have noticed that, and there's been an eagerness to jump into it. At the same time, I think we saw an initial wave of excitement around it as people went, oh my gosh, right now, everything's changed. This is the disruption. I want to jump in on this. And the challenge is, it's often a very heavy lift to get involved in healthcare. You do need to be, especially if you're selling into it, there's a lot of intentionality in how you approach it. I know that we talked before kind of this conversation a little bit about you need to figure out who's going to pay for it. And it's a complex system with I think a lot of people took an initial run at it, bounced off it because of the regulatory and the technology challenges, and now people are kind of taking stock again. They're regrouping, and maybe they're taking a second run at it with maybe a slightly different business model. They've kind of tried to address some of those initial challenges, and I think it's really over the next year and a half that you're really going to see the fruits of the last year start to come to fruition, basically, and you'll really start to see some of this stuff being implemented. And actually, there was one remark that I wanted to make for Frederick is about the question of kind of a national system. In the U.S., about 60% of people get their coverage from either Medicaid or Medicare. So, and that healthcare data is subject to much stricter requirements for shareability than private healthcare data. So in a lot of ways, 2/3 of our healthcare system almost is a national system already. It is still fragmented, it's true, but there is still a big part of that market that the government or regulatory change can come in directly and just kind of grab and say, if you want to play in this market, you have to do this. So just an interesting and often overlooked fact about our supposedly private system.
No, that's true, and I think that one of the things that when we think about a national system, and that could be taken a whole bunch of different ways, right? National system meaning a national network of systems. It could be a national payer, which you mentioned is somewhat exists because it's 60% is paid for by the government. But when we think about that, at least as a technologist or even again an entrepreneur, is okay, if there is one system, then that means all the data is liquid, and it solves the problem of when I go here, this doctor knows my history, and then when I go there, the doctor knows my history, and I won't have repeat tests and so on and so forth. And that is, that is a potential benefit. But I do think that, and this is somewhat anecdotal and maybe not scientific, but I somewhat agree with a comment that I'd heard that the pandemic has actually moved our industry ahead from a technology perspective 5 years, just jumped us forward 5 years. And in a national system, some of the problems of technology adoption would just kind of be prescribed and fixed because it's being run by a single entity. But since we don't have that, I think there is an opportunity now to start to recognize some of the value that could have come from a single system, because connectivity is happening because it had to, right? And one stat I saw that prior to pandemic, so prior to 2020, about 0.1% of visits were done via telehealth, right? Now 14%, at its peak, 14% of visits were conducted via telehealth. Not to say that number's not going to go down, not to say there's no reason to go see your doctor anymore, but the point is that if 14% of all visits were able to happen remotely, then that means a lot of practices have adopted some form of technology. And aside from just communication, we're also seeing data liquidity become something that now the industry is seeing as valuable. One thing, Healthjump's part of a great nonprofit initiative that we were very happy to be invited to, and that was the COVID-19 research database. Now, the COVID-19 research database is a database of de-identified and limited data sets from, and one being CMS data, and this includes claims and EHR data, mortality data, consumer data, all harmonized together, not from a single system. And from that, they've produced 41 published studies pertaining to utilization, costs, mortality, reopening policies, and so on and so forth, right? We haven't had a time in our industry to reap the benefits of everybody kind of working together until now. But now those pipes exist and that conduit exists. And whether it would have happened via national system or not, we're seeing it now. And so from claims data to clinical data being used and being seen as valuable for our situation now, as an industry, we're going to see it be used, be valued for other things. It's going to be used for, in my mind, helping doctors diagnose us, right? The idea of personalized medicine can be realized because the data is not skewed. I'm a patient of Penn. If Penn's got a ton of data, right? But if they were going to inform my care only based on their data, that's not going to be as good as if they compared me to somebody that's very similar to me across state lines, et cetera. And I think that we have the opportunity as technologists and as entrepreneurs to start affecting some of that change and seeing the value.
Yeah, you made a really good point about things like clinical decision support systems, where the only reason that we have the data to develop and test and implement these systems is because it was already being captured before we knew what the value of it was. We've worked on things like sepsis prediction algorithms that are looking at all these disparate healthcare data points it was not that they said we need to start capturing this, this, and this so that we can predict sepsis. It was that we are already capturing this info. We hadn't unlocked yet the value of it. And I want to make a correction. Scott Snyder in the chat helpfully brought up. I was mistaken about the percentage. I had it flipped. My apologies. 60% of people are covered by private insurance. It's about 35% of people who are covered by Medicaid and Medicare. I'm a big stats person, so I wanted to make sure that I got the correction in. And thank you, Scott. So you were talking a little bit, Cliff, about where these emerging markets are, and where these new things are coming from. So let's talk a little bit more, about that.
Sure.
Because when there's, like you said, when there's these major changes in any industry, a shock, you said, there's the possibility for disruption, innovation, new business models, discovering new value. I found a statistic that the healthcare data market will increase from around $11 billion a year in 2016 to a $70 billion industry by 2025. So let's talk about where some of those new opportunities specifically are likely to arise.
Yeah, wow, that's how much time do we have? That's a very loaded question, and while I'm certainly not in a position to predict the future, one thing that that I am able to see, just because of the nature of Healthjump's business, and Healthjump, we're connecting, whether it be software vendors or service providers, to the data that's in practices and hospitals, so that they can provide technology to, whether it be care delivery, life sciences, et cetera. We kind of get to see, because of this network, what's working, right, and what's being adopted, and what's new, and what we think is interesting. And so, but like I said, I can't predict the future. What I am seeing happen now, and what I'm kind of expecting to continue to grow, is really in a couple of different buckets. So one is in like the care delivery bucket. So care delivery meaning your doctor's visits, your trip to the hospital, those types of things. We're seeing an emerging market in ancillary services, right? So that's not necessarily anything brand new. The idea of going to an urgent care, let's say, isn't brand new, but rethinking what is an ancillary service, and do I need to actually get a physical exam during that service? And we're going to lump it into two categories: yes or no. And so if you don't need to see somebody, what can be done remotely? And a lot of chronic care management can be done remotely. There's remote patient monitoring solutions that I think are really going to revolutionize how we consume healthcare. Like we've mentioned a couple of times, there's widespread telehealth adoption that I think is going to become. I think we're just tipping the iceberg on that, because with COVID, we saw regulators starting to change their tone on whether or not doctors can practice medicine across state lines. And so if the best specialist in the world can be made available to a wider population, we're going to start seeing these subsects of specialists and sub specialists. And there's got to be a way, from a technology perspective, to get patients in front of those specialists. And then things not quite as serious, but also I think very important, is the adoption of in care delivery of businesses in every other industry have a reputation management like budget, right? Like if somebody Googles us, what are they going to find, right? And so we're starting to see healthcare look like that too. And I think it's great, because healthcare is something that hasn't operated in the same kind of free market space, where it did need to be competitive, and the best care can be found if you're searching for it. And so I see the care delivery space changing a lot. I also see the patient connection, and I don't want to say patient engagement either, because I'm saying patient connection a little bit, because our involvement in healthcare as a patient is really kind of up to us. I mean, yes, it's healthcare. We just want to be cared for, but there are real changes in what us as patients' perception is of healthcare. And so, for example, one thing that's been an issue in healthcare in the US has been cost, right? Very expensive these are things that we already know. And so while this is not a single payer system, but it is coming from CMS, from the Centers for Medicare and Medicaid, is that doctors are being penalized for readmissions.
Mm-hmm.
If you're following a doctor's protocol and you have to go back to the hospital, they're getting penalized. I think 528 million. I have my note here. $528 million in Medicare penalties every year for practices that have a protocol for a patient and they have to get readmitted to the hospital. So what does that mean? It means that the healthcare industry needs to know more about us while we're not in care. That's a massive, massive business opportunity. Mm-hmm. And our expectations as patients are changing. Now, I read a stat that millennials are nearly twice as likely as non-millennials, so 44% versus 25%, to feel that their provider is just reactive about their issues. They're just treating their symptoms as they are. And millennials who've been admitted to the hospital are more likely than older counterparts to feel uncertain as to what to do after they're discharged, right? Mm-hmm. So remote patient monitoring and chronic care management, I think, are massive emerging markets. And lastly, and immediately, is big changes in billing and financial.
Yeah, absolutely. Yeah,
I
was champing at the bit to mention that, because there's regulation being rolled out. We're about halfway through the rollout right now, called the 21st Century Cures Act, and it's a huge, was a big bill that did a lot of different things. That was actually passed at the end of the Obama administration. I think it was actually the last bill that was signed into law by them, and it's only started being implemented. The actual implementation of the regulations only started about a year ago. One of the things that it mandates is much greater shareability of claims data and clinical data from insurance companies and other payers, including public payers. And providers, and two very different types of data, but both of which our ability to access has been significantly limited in the U.S. up until very recently, and I think technically even still legally now. Your healthcare data is not your property; it is the provider's property. They've been required to share it in certain specific ways, but there was a lot of leeway where a provider could just say, "No, we can't make that available." Or here it is in some strange format. Here's, in an 800-page binder. Or they could often just say, no, we'll only share that with another practice or another provider. With this new regulation that's increasingly changing, it's also changing on the payer side. We've been involved at Arcweb with something called the Karen Alliance, that is working to develop consumer standards for data sharing. And one of the focuses has been billing and claims data from payers that is now being required to be made available to patients and kind of agents authorized by those patients on behalf of them to get it. And that opens up the ability to have much greater pricing transparency. It opens up much greater ability and leeway for employers under our current system to identify what the ideal coverage model is. It helps. It opens up possibilities for even within kind of the billing industry subset to be able to reduce costs for all participants by being able to process and digest this claims data that previously was kind of just locked up somewhere in different strange formats, and increasingly that's being standardized. And so I think we're going to see a ton of developments there. And of course, the critical thing is people, especially businesses, very much like their bottom line improving. And if you can reduce healthcare costs for a business, if you can ensure better reimbursement for a provider, that impacts the bottom line directly. And as much as we always try to put the patient first, oftentimes the barrier to something happening or not happening is not does this improve the patient experience? And this is a whole other problem. But does this make financial sense? And that's one area that the financial sense is very, very clear. I think that we're running low on time. Is that correct? I'll ask one of our moderators. I want to make sure.
think we maybe started maybe 5 minutes late. Maybe if I,
Okay.
my calculation, I think we got maybe 3 minutes left or so.
Okay, great. Well, maybe we should jump ahead to our wrap up question, which I do want to touch on pitfalls, but I think we did touch on a couple of them. But just to kind of start wrapping up, this has been a really terrific discussion, and I wanted to close with a few thoughts from each of us. I guess about kind of advice or tips for entrepreneurs, anyone who might be interested now and energized in jumping into this industry, anyone who's been tasked with investigating whether this makes sense, whether they can apply their existing technology and products to healthcare, and whether this even makes sense to take that plunge, acknowledging that it still is a very complex industry.
Well, for me, if anybody listening is in what they would consider the healthcare market, I would say the two takeaways would be, one, think about how you can harness the value of the data that you have via new products and services that exist. This is something that didn't exist before, and now we recognize, I think across the industry, we're recognizing the value of data. And so we need to be thinking about how we're capturing data for answering the unknown unknowns of the future, right? Let's not just, when we have our general ledger, that goes in the general ledger system, right? When we have our clinical records, that goes in the clinical record system, and they're completely siloed, walled off, and they don't interoperate. And the value of that data is limited to record keeping. The value is limited to, again, financial reporting or something like that. Let's start adopting the strategies of other industries, and let's start using data to predict things. Let's start using data and storing our data in a way that it can be reused and value can be gleaned going forward. The second thing is that we're now legally required to think about whether or not we're being data blockers. The 21st Century Cures Act that you had just mentioned, there's some strict penalties for any healthcare company that has patient data that doesn't make that data available to those that are authorized to obtain it. And so we need to be asking ourselves as healthcare companies those two questions. But if you're not in healthcare, right? But these changes, I think, still matter, and we should be thinking about two things. Even if we're not in healthcare, is that healthcare is becoming much bigger than the four walls of a clinic or hospital. And so take the opportunity to say, does my product, does my service, does the thing that my company does offer value to healthcare in the same way that it offers value in the industry that we're currently addressing? And I think a lot of times that answer is going to be yes, because it's not just some of like the telehealth stuff that we're talking about, but it does go into the life sciences space, which has a big initiative, and it's worth a Google if you guys aren't in healthcare. It's referred to as HEOR, health economics outcome reporting. This is how the life sciences industry is kind of being taxed with lowering the cost of healthcare across the country. And so these operate like very big businesses, and they don't feel like clinical visits. And so, and lastly, one thing we shouldn't be forgetting as employers, that we also need to be thinking about how we're best serving our employees. Absolutely. And the things that we're offering them.
Yeah, absolutely. And just the fact that we talk about choice in the healthcare system, but for the majority of people, 2/3 of the people in the country, you go to your job and they say, this is the coverage that you're going to get. It's, the choice right now is very much, for the most part, not with patients. Scott just asked a really tricky question.
I'd love to answer that if I can.
I will say, I'll go on record and say yes. His question was, do the EMR vendors wield too much power in controlling access to data for outside innovators? It's certainly the 800-pound gorilla in the room currently. Is, I think it's like 95% of all healthcare data is in hospital EMRs. Even though the regulations are requiring that to open up, this actually segues very nicely into one of my points, which is healthcare remains a moving target. Don't be fooled by the passage of new regulation, meaning that like a light switch has been, flipped and suddenly the world has changed. These things are being litigated, quite literally litigated, or metaphorically litigated. A lot of the regulations in the 21st Century Cures Act say this must be done. They don't specify how it must be done. They say, you must adopt the standard interface for X. They don't say what the interface must be. They don't specify the particulars of it. It's a lot of back and forth, and admittedly, a big player of that is the EMR vendors. And I'll say, to their great credit, over the last two or 3 years, there has been a lot of motion. So I do think there has been a good faith effort to improve that. Some Smart on Fire definitely does not solve it, but it does help a lot. And I think right now the question is, what models for integration are ultimately going to meet those needs and will become kind of standardized and accepted, because there's been a bit of standardization through the regulations. But again, the implementation is not fully defined. When we say like an HL7 implementation, that looks very different at one hospital than another hospital potentially. But this kind of goes right into what my second point was, which is we don't need to repeat the mistakes that others have made of trying to jump into this industry. Last year, this big initiative, Haven, from Amazon and Berkshire Hathaway folded. You don't need to try to charge in as they did and force yourself in. Get involved with organizations like HL7, the Karen Alliance. We've got a talk coming up in the end of June, going more in depth about regulations from the 21st Century Cures Act with representatives from some of those groups. I would say if you're interested in jumping in, you can learn a lot by getting involved in the people who are already doing this work. I would greatly encourage you to do that. And I heard the beeping. I know our time is up. So thank you again, everyone. Thanks for PACT for having us. And next, I am happy to welcome Karina Edwards, CEO of Quill, for a discussion with Neil Ravitz from Penn Medicine on how consumer and home healthcare trends evolved over the past year and what's ahead for companies working to connect, engage, and empower patients along their health journey.
All right. Thank you for that. Great session, guys. Great to be here. Thrilled to be here. We are going to talk about consumer trends in healthcare. And so we're excited to dive right into the discussion, as so much has changed in healthcare over the past year and still evolving. Quick background. I'm the CEO of Quill. We're a digital health platform engaging consumers and their caregivers as they organize and navigate their health life. And we're also the joint venture between Comcast, NBC Universal, and Independence Blue Cross. So thrilled to be here and a PACT member. Joining me is Neil Ravitz, the Chief Administrative Officer, Musculoskeletal Rheumatology Service Line, and the Chief Operating Officer for the Department of Orthopedics at Penn Medicine. So welcome, Neil. Thrilled to have you here.
Thanks for having me, Karina. You and I have had the opportunity to work together for the last 2 years or so on this endeavor, and it's been great to work with you. So thanks for having me. I'm excited about it. These last 14 months have just seemed to be a roller coaster and a whirlwind, both in our personal lives and our professional lives. But I think so much is changing in terms of consumers and how they consume healthcare that I think it'll be a really interesting conversation today.
Yeah, super fun. So I think let's start with the big overarching trends in healthcare. The big shift we heard earlier on our panel to telehealth and virtual care, I think was inevitable for healthcare organizations. But I think if you ask anybody, nobody thought they would accelerate as fast as, okay, we had 5% of our visits and now we have 80% of our visits. So before the pandemic hit. So starting, really with your firsthand experience, how was it at Penn in the orthopedics and across the health system as you had to make that significant transition?
Yeah, it's funny you mentioned that, Karina, because it feels like we didn't just jump in with 2 feet. We jumped in with 2 shoulders, 2 arms, everything all in. Because to be honest, that was the only way to deliver care. If you think back to the middle of March of 2020, some of us had started to figure out some platforms and had started to do, as you mentioned, a small amount of our care via telehealth visits. But then all of a sudden, there was no way to see that patient, March 18th, March 20th of last year. And so it accelerated the change. And I think especially in a subspecialty like orthopedics, in which you think of people being hands-on, you think of physicians needing to bend your knee, to test your hand, to feel whether the bone or the joint is right. it was such a learning curve to be able to switch that over to telehealth. And I think, like anything that changes that quickly, I liken it to a pendulum. The pendulum shifted so far in one direction in which, we were doing everything telehealth. It was natural for the pendulum to switch back a bit. And I think that's what we saw in the summer as people returned to some normalcy in their lives. They wanted to get back out. They wanted to be on the beach. They wanted to play basketball. And, for us in orthopedics, people were going to get hurt. That was part of our business. I think there are some things that have probably shifted a little bit more permanently. And I think some of that's for the better. One of the examples I'll call out is in orthopedics, we had long believed that patient education was really a critical part of driving an outcome for a patient. And there were studies done that said, listen, if you send patients to joint class, they will be more educated about what's going to happen to them. They'll partner with you in their healthcare, and they'll get to better results. And so for many years across the country, what we did was we tried to force patients to go to a joints class. And we had great results with it. It was one extra visit for the patient. Sure, that's slightly inconvenient. You have to come downtown. You have to go to see your doctor's office for this class. And now this digital world, and obviously some of this through the partnership you and I have worked on, it's just changed things. I don't think that we'll ever go back to forcing somebody to come sit in a classroom. And so as much as I think there's been these massive shifts in some of the things like telehealth, I think there are some other things that we're saying, boy, maybe we need to relook at this. And maybe there is a more patient-friendly way, a more consumer-centric way that we can deliver some of the things that are critical to the health outcomes of patients. I guess I'd also ask you a similar question, Karina. What are you, seeing specifically, maybe anything on the payer side? I'd love to hear about.
Yeah, so I think, great points. For us, where we're seeing a big change is just the consumerism. I think it's an overhyped word. At the same time, we all expect connectivity. We expect ease of access. And I think it's now, and even before this, we just wanted this notion of health integrating into my life, because something I always say is that nobody wants to be a patient, right? Nobody wants to be categorized as a patient or a member or an employee. I'm just a person. I have a lot of facets to my life, and sometimes I have to be a patient. And so, I think when you think through the way we're addressing consumerism and bringing health to the home, the ways that are resonating is if you can be on every pane of glass. Like, how do you think about meeting people where they are in different ways? We've experimented with phone and text and email and web and even the television, and being able to bring a consumer experience around activating and engaging people in their care and really rethinking the digital touch points, right? So much hype was around the video visit. But what I think we all saw was the video visit was the easy part. We've been doing this for a while. It was the scheduling, billing, capture, coding, all of the things. And I think the one, building off the last session, one of the big transitions when you become a player in the digital health space is you have to understand the workflow, and you have to really understand the bigger pieces, because it's not just about this one interaction. Right? How does the same patient that's coming in for joint class might also be going in for a different type of diabetes treatment, or could be a kidney failure patient, right? There's so many aspects of their life, and their health life is just one piece of it. On the member side, I think what we saw is the willingness to consume a lot more information online. Right, we're dealing with populations that, as they're bridging the digital divide, and we'll get into that in a little bit, but they're coming in with a literacy rate that's a little bit lower. And so, how do you also drive up through nudges and text and reminders to get the gaps in care covered? So we did see a lot of folks during COVID really dive in and consume more. Even in your patients alone, it was funny. Pre-COVID, they'd come in 8 minutes, 10 minutes, they'd check around. This looks fun. Okay, I'm ready for my surgery. Post-COVID, 24 minutes on average. Like they're consuming the data, they're really in there. So it's been fun seeing that. And the last point I'll make is all of us expect personalization. Do not give me a one too many text message. Please do not make me feel like I'm like some robocall that you're sending out to everybody. Just pretend you know me, like fake it, and then just have a little fun, because it's not only about delivering a branded experience. Clearly Penn wants to do that, but it's also delivering a Penn experience where the individuals think, wow, they understand me. They're meeting me where I am. They know how to get in touch with me. And by the way, they're activating, my caregiver. And so, as we kind of think about this, I'm going to switch a little bit to talk about disparities in care and health equity. And, this transition has left some out, right? This is the Digital Health Series, and some people aren't digitally native. And so just wondering if you can comment a little bit on how you're seeing that divide across your patient population.
Yeah, it's a great point. As we get excited about some of these technologies, we have to think about what's happening with the patients, and maybe no time more than in the last 12 to 14 months have we kind of seen some of those barriers around health equity start to show themselves. I'm a believer that there is a big responsibility that lies on the academic health centers around the country for a couple of reasons. One, most or almost all of them are located in urban metropolitan areas, that often experience a lot of the patient populations where there are these big disparities in health equity. So one is I do feel like the Penns of the world and those in New York and Boston, LA, so on and so forth, have a responsibility to help figure out what is going to work best across all patient populations. And when I say that, whether you're trying something that's texting a patient or phone calls to the home, or even emails. It seems almost antiquated to think that we're going to email patients, in 2021. But figuring out how do you meet the patient where they're capable of communicating with you, and that may be different for different sets of populations. And why I believe it's a responsibility of those academic health centers is they have the ability to do some of this research. They have the ability to invest. To use residents and fellows and medical students to help us figure out what are those right ways to communicate with patients, because it's not easy. And that maybe the last point I'd bring up is the partnerships that we've started to develop with industries. And whether it's our partnership with you at Quill, Karina, or many of the other partnerships that exist right now, people are trying to figure out how to get technology into the homes, and not just into the homes of the wealthy, into the homes of the patients that could benefit from that care. And I think, to be honest, even the insurance companies have been good partners in that sense, because they recognize that not having that technology is going to lead to worse outcomes and more costs. So that's kind of my view on it. I think we've got a lot to figure out there. Certainly nobody has cracked the code on how to get through some of these barriers from a health equity perspective. But I think we've also made a lot of progress this year.
Yeah, I want to jump on there because one thing I'll share with folks, and it's a little bit of a plug, just because being part of Comcast on one side of our parentage, I didn't know that they even had this program, and it's a program that is regulated by the FCC, so it's not, helping Comcast profit, but it's called Internet Essentials, and so we partner. We're AmeriHealth Caritas is a customer of ours for their Medicaid population, and so one of the things we're trying to do is get that population connected and making sure that they cross that digital divide. And with Internet Essentials, they can literally get internet in the home and a computer in the home for $10 a month. And so something like that to really get health literacy up and connect the home. And now it's schools going virtual, really trying to get populations to cross that chasm. And, I think switching gears a little bit now, for those that are digitally connected, have you noticed differences in the consumer behavior? I mentioned that point about people spending more time in the content, but anything else that you're seeing across the board of how consumers are changing in interacting with you digitally?
Yeah, it's a great point and a great question, because I think we have seen some differences and some changes. Maybe people are spending a little less time commuting, and maybe they have a little bit more time to focus on this. Through the project and program that you and I have worked on, we send out these reminders to patients, and there's kind of this magic point, maybe around 12 or 14 days out, where patients suddenly realize, like, hey, this procedure is coming, and I need to know about it. And so you mentioned the amount of time that patients are spending consuming the information. They want to be educated. They want it from a trusted source. And listen, I'm biased, but I feel like Penn Medicine or Penn Orthopedics is a trusted source. So they're not out. Maybe they're out on WebMD or other places like that. But when we're sending them, as you mentioned, personalized information about their journey, they want to consume it. And so they're consuming more of that information. And to be honest, that's led to better results for us, which is what we wanted when we started the partnership. We're seeing a reduction in readmissions. We're seeing a decreased length of stay, and we're seeing increased discharges to home. That's kind of the trifecta for us in knee and hip replacement. We want to see those better results because we want patients to be home and recovering. We don't want them hanging out in the hospital. So much has changed. I mean, 10 years ago, patients were staying 5 days. That was, normal for a knee and hip replacement. And now we're educating them on being up and moving around, and being at home is the best place for their recovery. So we're seeing differences, in the way they consume the information that we offer to them. But probably most importantly, we're seeing some good differences right now in terms of their motivation to be a partner in their healthcare. And that's really important. That's what I think is most impactful.
Well, and so, starting this big change, there was always some inherent resistance, right? Don't move my cheese if I'm a doctor in this mix, and or the clinical teams that care for patients. And so, when you think about this, we've thrown a lot of technology at the doctors and the nurses and the APPs and the schedulers and the therapists. And so, what is your team looking for from digital tools? What brings them the most value?
Yeah, and it's probably something that I hear from the physicians most about. I always start by answering something like this with a premise or a fundamental that doctors and PAs and pharmacists, everybody, they want to take good care of patients. I don't think they would have gone through, med school, nursing school, so whatever you describe, if they weren't interested in taking good care of patients. So they want to do that. But let's be honest about what their world looks like. A bit more onerous in terms of documentation for tasks, documentation for billing purposes, documentation to make sure they're not involved in a lawsuit. So all of those things have become more onerous over the last, whether you've been practicing for 5 years or 50 years. And so when I think about what do physicians want from digital, health apps or companies or things like that, I think number one, they want to take good care of patients. So that should obviously be the first and starting point. I think the second thing should be that in some ways they're almost on information overload. And so they're not necessarily looking for another click within their EMR. They're not looking for necessarily another dashboard. What they're looking for is an efficient way to take care of their patients. And so if you can give them really good information in small bits and pieces and make their patient a more educated patient, a more engaged patient, I think you get to this point where the relationship between the physician and the patient can be based on more knowledge, a greater understanding, and this more efficient way to care for patients. And I think that's what most people are looking for. They're looking for some shared responsibility. And so, if I was starting a digital health company right now, I would tell anybody, Karina, to kind of start there. make sure what you're doing is driving a better outcome for patients. Because if you are, you have the physicians, you have the health systems, you have the payers hooked. But then make the care about being more efficient. And there's lots of inefficiencies across our healthcare system. That's well documented and noted. But things that companies can do to make things more efficient, that's really what's going to separate you.
No, it's a really great point. I think when we think about some of those components and how we now go forward, I do think there is this what's ahead in healthcare, because now with that in mind, just from the efficiency perspective, I'll switch it up a little bit here on you, but the remote patient monitoring, things that are coming, the outpatient care shift, just some comments there, because just the integrated into the workflow. Again, I'm always going to go back to that piece. I've always said you can't deliver value unless you really understand current workflow, future workflow, and it's not about tech, right? Tech is a piece of it. Like, you can make technology do anything, and so like, how does the tech empower? And so, kind of what are some of the things that you're thinking about from a people, process, and new technology exploration as you move forward and look ahead?
You mentioned the technology in the home and the monitoring systems. I think that presents a huge opportunity. And whether you're dealing with heart failure or diabetes, I think ways of remote monitoring patients and truly understanding what their personalized baseline is, and then understanding when they're approaching an area where they're going to get in trouble, and trying to get in front of the ER visits or anything like that. That's a huge opportunity, and I think there are several in that space that are really doing a nice job, and I think that's going to continue to just develop and gain momentum. The example that I often hear from our CEO, Kevin Mahoney, Karina, that is kind of changing this whole perspective on where care is delivered. And to be honest, we have to give COVID credit for forcing us to do some of these things. And maybe the example I'll point to is, we, like many large health systems around the country, have prided ourselves on the size and scope of our cancer centers, and being able to deliver just cutting edge, unbelievable treatments and therapies to patients. And this has forced us, because those patients were immunocompromised, because they were so sick, to figure out ways to deliver infusion therapies, their chemotherapies that they used to come to Philadelphia for. They used to go to downtown New York or Boston or LA for these treatments. And we figured out how to deliver their health care in their home. And while that story is amazing for that individual patient, for that individual loved one who needed that care, right? I mean, they had serious illnesses. If you step back from that and just think about that for a second, what did we do? What did we accomplish? It suddenly makes you start to rethink even more. I'm not suggesting we're going to be doing knee replacements in anybody's living room anytime soon. But I think this really has changed our perspective on where and how you deliver healthcare. And believe me, there are lots of challenges to this, none which can be ignored, maybe less than the payment structures for these types of things. But if you think about that example of delivering chemotherapy treatment to somebody who's has a disease as serious as cancer in their home, and being able to monitor what's happening for them, and treat their disease and hopefully cure them, I think if you look at it through that lens, our minds will open up to new possibilities. And it takes a village of people. It takes the clinicians, who have been practicing medicine and know their patients. But it takes, smart people from all sorts of different walks of life to come in and say, what if it wasn't like that? what if we tried something different? And that to me is what's exciting. I think it'll continue to change. I'm hopeful I'll be retired at some point before this is all changed over. But I think there's so much changing that, it's going to be an exciting, probably 5-year period in healthcare where we continue to push that boundary of where healthcare is delivered and what's the technology needed to deliver it.
No, it's great. I think I'm going to take that point and lead us to wrap up here because, when we think about this from our perspective, not just from the Quill perspective, but also just from the broader big tech perspective, we're exploring a lot with the R&D labs at Comcast, looking at ambient sensing, what we can do with the 83 million homes that we're connected in today. How can we deliver new experiences, both from an education perspective, an engagement perspective, and now I shouldn't have to physically enter information to get it back to you, right? The notion of being able to figure out really just interesting pieces of technology, right? Some of this ambient sensing thing I'll go into here. Medication adherence, as we know, is a huge issue. Some of the simplest hacks, and it's a hack, but it's a new technology. It's establish a drawer and put a little sensor on it, and you at least know, are they opening the drawer? Are they getting into the medication? There's all these little dispensing machines, right? There's so many ways we can making the smart home interact around you and not feel invasive on you. And so the trends that, we'll just end with here are clearly bringing care to the home, thinking about end of life in a new way, right? Really, really thinking about the discussions that you have to have and getting your family members around that decision, thinking about how we want to deliver care virtually and what data is noise and what data is actually clinically relevant. And so separating, all the things that come out of this lovely watch, I don't think 90% of it anybody wants to see clinically. And so what is the thing that really matters in my care? And so, great discussion, Neil, amazing partnership. I'm going to wrap up here and turn this back over to Dean Miller. Dean, thanks so much for having us. This has been a great session and really appreciate the time.
Karina, Neil, Kurt, and Cliff, just some really terrific conversations, and really appreciate all of your time, all that you're doing. Neil on the front lines of care, Karina certainly, from a application of technology, and same with Kurt and Cliff. We're excited to present you and all that you're doing to push forward through the impact of COVID and beyond. Care, obviously an important segment, not just to society, but here in Philadelphia as a driver of our economy, of our innovation. And again, want to recognize and thank our sponsors for this program, Independence Blue Cross, Duane Morris, and Eisner Amper. We're excited to actually transition to tables. As you know, Remo provides the opportunity to have open conversations, and we're now going to invite you out of presentation mode to join a table, have a conversation, and just keep in mind, you can, again, come off your camera on, mic on, to have those conversations, and you can switch tables very easily just by double-clicking on a new table. So with that, again, thank you to everyone, those participating here this morning, and look forward to seeing you at a table for further conversation.